Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nairos. Today, we are talking to Dr. Diana Kim, who is a neurologist here at Kelowna General Hospital. Do you know the signs of stroke? Do you know the signs of a mini stroke or a TIA? Well, it's really important for everybody to know the symptoms and the signs and the risk factors for stroke. Stroke is the number one cause of disability in adults in Canada and the third leading cause of death. This is a subject that is important to all of us. You're going to want to listen up. In Canada, someone experiences a stroke every 9 minutes. It's the third leading cause of death and the number one cause of adult disability. Yet many of us still don't know what stroke really looks like, how it presents in different people, or what happens in the minutes and hours that follow. Out of all the areas of healthcare that we explore on this podcast, brain health is one that fascinates me the most. It's powerful, complex, and still full of mystery. How the brain functions, how it responds to trauma, and perhaps most remarkably, how it recovers. And when it comes to stroke, I've learned that timing isn't just critical, it's everything. So today's guest is Dr. Diana Kim, a board-certified neurologist at Kelowna General Hospital. She works in acute stroke care and recovery, supporting patients through some of the most critical moments of their lives. From diagnosis to the delicate early days of healing, Dr. Kim helps translate urgency into action and trauma into a path forward. And we'll talk about something called TIA, a transient. I should practice these things. Help me, Dr. Diana. Ischemic?
Yeah, so TIA stands for transient ischemic attack.
Right.
Also known as a mini stroke.
Mini stroke. Okay.
Yeah.
And a TIA causes temporary symptoms, but no lasting damage. Still, it's a powerful warning signal. And for many, it's not just a red flag, it's a second chance, a moment to intervene before something more devastating occurs. We'll also explore a topic that doesn't get nearly enough attention, women's brain health. Women are not only more likely to die from a stroke, they're more likely to face worse outcomes and experience symptoms that are misunderstood or dismissed. So we have lots to talk about, and we've stolen Dr. Kim away from her clinic today to talk about all this stuff. So let's dive in. Welcome, Dr. Diana Kim.
Great. Thanks for having me. Excited to be here.
Yeah, it's great to have you. We have an opening tradition on the Wealthy Podcast. We are very curious. Most of the people that are sitting in that chair come from having a passion or an experience at a young or early age with health or healthcare that has caused them to kind of move towards the path that they're on. So I'm wondering if you can just share, like, how did you get here and sort of what inspired you to become a neurologist?
Sure. So I was inspired to pursue medicine just because I wanted to help people, and I felt like medicine was a good blend of all the things that I like to do, like working in teams and combining knowledge and understanding what happens physiologically and then using that directly to impact people. And neurology specifically was a little bit always of interest to me. Like I did a master's in neuroscience before med school, so I was a little bit interested in the brain beforehand.
Just a little.
A little, yeah.
like 7 years.
Exactly,
little,
yeah. And I think that, once I started rotating through like electives in med school, I just really grew to neurology. I think it's a very neurology is interesting because I think neurological diseases can be very disabling and quite visible and very personal for people. So, for example, losing your ability to walk or talk are very difficult for patients, and being able to help them through that, either through reversing a stroke or treating something like MS, can be really rewarding.
Mm-hmm. Amazing. I'm curious because we have kind of a gamut of topics that we're going to jump into, but from your perspective, Who needs to hear this conversation today, or who's going to get the most benefit out of it?
Ooh, everyone. You don't have to put that in.
Of course.
I think, I think everyone can benefit. I think the brain is fascinating and very interesting, and it controls everything, like for your movements to like other organs, and understanding how it works and the importance of it can be of relevance to patients, other physicians.
And we're going to talk today quite a bit about stroke care. And one of my understandings about stroke, I learned a lot. We did a stroke campaign a couple of years ago, and I learned a lot from your colleagues. But one of the things I learned is that the biggest risk factor for stroke is age. And last time I checked, we all do that. So like you said, it would be relevant for almost everybody.
Yeah, definitely. And I think that, age definitely is a risk factor. And also young people have strokes too. So,
Totally.
and there's various reasons for why people have strokes. Like there are more rare causes of strokes, like dissections, where the artery can tear, or people can have congenital heart disease or venous thrombosis in the brain. And so I think, that's what makes strokes fascinating. I think just the wide breadth of the things that it can be caused by are very interesting.
Yeah. So just kind of setting some context for the conversation. According to the Heart and Stroke Foundation of Canada, there are approximately 62,000 strokes in Canada each year, which equates to 1 stroke every 9 minutes, which seems like a lot. What do you wish more people understood about this statistic?
I think that there definitely is a large proportion of strokes we're seeing. It's something that we see more often with our aging population. And what I wish that people knew more about that statistic there was maybe more just how to recognize a stroke, and that recognizing that time is brain and acting quickly can improve someone's outcomes dramatically.
Yeah, and I think as you said also, not kind of pigeonholing, and we can talk about some of the characteristics of an early stroke. We're going to get into that. But like not just pigeonholing it as this is a medical emergency or condition that impacts, aging people or the elderly. It is something that happens to younger people. We have cases and stories that we've heard of young moms in delivery that end up having a stroke. So it's really good to have the information, all of us, to be able to spot kind of the symptoms of when a stroke or early stroke is happening. I want you to unpack, in the intro, we talked about TIA. I pride myself on being able to say some of these really long or difficult words in medicine, but sometimes I don't get them.
Me too.
But we talked about TIA. Yeah. So, and why it is often called like a warning stroke. Maybe you can just unpack that. Again, what is TIA, and like how does it manifest, and why is it sort of, because this is an area of specialty for you, correct?
Stroke is my subspecialty.
Yeah.
And that includes TIAs.
Yeah.
Definitely.
So what is a TIA? What does it look like? How does it present? Who gets them? Like all of those things.
Yeah. So TIAs are essentially lumped in a little bit with minor strokes. I guess by definition, a TIA is stroke-like symptoms that reverse within 24 hours, but it's not always the case, because oftentimes on an MRI, we may see what's called an ischemic little hit, like a DWI restriction, and that can be also considered, what's the difference between a TIA versus a minor stroke? Because you see a stroke on the MRI.
Like what is the difference between a TIA and a minor stroke? I didn't even know there was I thought there was just like a capital S stroke.
Yeah, no.
Okay.
So they're kind of lumped together into one category, like TIA and a minor stroke.
Okay.
And they're treated the same. But they can present in many ways, and that's what's fascinating about the brain is that you can get anything from weakness on one side to double vision to loss of ability to speak, slurred speech. Some people get very atypical symptoms, and we can talk more about that. Like women are more likely to get atypical symptoms. I've had some patients present with visual auras, like migraine auras. So they see like sparkling lights and it ends up being a first time TIA or minor stroke. Or they can get like double vision, vertigo, headache. There's basically a whole host of different symptoms, depends what part of the brain is affected, what artery is affected. And so that's the challenge sometimes with diagnosing TIA is that it can be really misdiagnosed, and there's some subjectivity to it for sure.
Yeah. So like you said, I'm just trying to wrap my head around this. Mm-hmm. The symptoms resolve in 24 hours?
Within 24 hours, but most TIAs, I would say, resolve fairly quickly, like within 15 minutes or so.
Okay. So like I'm sitting in my office or I'm in a meeting or whatever. And all of a sudden I kind of start to feel a little woozy. I get an aura, maybe some weakness on the right side. And I'm wondering if maybe I'm just not feeling well. And then half an hour later, I'm like, oh, okay, I'm okay again. Is that like, should I be like, is that what I'm looking for?
Yeah. So TIA has a lot of mimics as well. For example, you can have like a compressed nerve or like carpal tunnel or radicular pain or neuropathy issues can mimic TIAs, or blood pressure changes, or maybe you're feeling a little vasovagal, or
I'm feeling a little
not you, but
you just let your doctorish show.
We don't
How do I feel a little vasovagal?
So for example, if your blood pressure may drop and you just don't get enough blood flow to the brain, and that makes you feel lightheaded. So there's a lot of mimics, definitely. And part of our job as stroke neurologists is to diagnose and figure out what's actually a TIA or a minor stroke and what may be a mimic.
And would typically I have a lot of questions. And I think this is really good. This is part of why we do this podcast is because like people like you have such great information, but not everybody has access to people like you every single day. So I'm just going to ask all the questions. Okay. So if somebody experiences a minor stroke or a TIA, but they don't necessarily know that that's what it is that common?
Sometimes.
Like, will people just ignore it and move on with their day? Or will they be like, oh, I didn't like that, I'm going to go, I don't know, to Emerge or my family doctor or what?
I would say anecdotally, personally, when I see patients, most people know something's wrong.
Okay.
Yeah.
Like it feels that strange.
It does. Or like sometimes. Yeah, exactly. they know something's different, something's wrong. It's something they've never experienced before.
Okay.
Some people find that if they have known migraine auras, it may feel different, for example, than a typical migraine aura.
Okay.
Like it's not just the sparkling light, something's different. So usually people come in knowing something's wrong or something's different, or this is something they've never felt before. And so when we see them, we go through all those things like the symptoms. And
do they have a headache? Like, is it like
sometimes yes, sometimes
what is it?
no.
How does that?
Oh. Usually not often, but sometimes people do feel headache.
Right.
Pain.
And is it like, you're going to tell me it can be any of these things, but is it focal or is it like more all over?
It's honestly really hard because like when you look at TIA symptoms, there's so many different possibilities and some are really non-focal and vague, and headache is one of them. It could be different with everyone.
Okay.
And that kind of also goes back to what the cause of your TIA or stroke is. For example, if you have like arterial dissection, like a tear in your artery, more likely there's a headache, and there's a specific type of pain typically that may come with that if it's a, say, vertebral artery dissection.
And does that just happen like randomly, or is that like an injury? Like say you're playing hockey and you get a hit.
So sometimes through trauma, or sometimes just like non-traumatic and randomly or spontaneous we see it. Okay. And there's some people who are maybe a little more predisposed to dissections.
Okay.
Yeah.
And if you've had one are you more likely to have another one? Like, I'm imagining
Yeah.
what is happening in the brain. It's in the brain when you're having a minor stroke or a TIA.
Yeah, so that's why they come see us. And
Yeah.
so we do our whole assessment, and our goal is to first diagnose it. Is it a TIA or a minor stroke? What caused it? And do the investigations and sort out what the cause or the stroke etiology was. And then, depending on what the cause is, then we can risk stratify more and then tailor management.
Right. At its very sort of fundamental level, though, is it, this is what I'm at. This is the layperson in me. I know a big capital S stroke, blood clot in the brain,
Mm-hmm.
very, very bad. Little baby stroke or mini stroke, TIA. Is it a small blood clot in the brain that just kind of stops and then moves on?
So sometimes it can be a larger clot that probably just cleared itself,
Okay.
and that person probably got very lucky. Or sometimes it can be smaller arteries that are involved.
But that's kind of what is happening. Is
There's a temporary
fundamentally
loss of blood flow, exactly,
in
and
the
then
brain.
in the brain, but then either the brain makes up for it or it clears.
Right. Okay. But it's still something that we should be concerned about because something caused it.
Yeah, we definitely. So when someone has a TIA, their risk of a recurrent event or a
Yes.
stroke is higher in the next coming weeks or several days. So ideally, when someone has a real TIA, we would like to see them fairly quickly. And then we investigate quickly, and we can put them on the appropriate medications or management as needed.
Okay. So two things.
Mm-hmm.
When somebody experiences some symptoms like what you've described, right, where it's disruptive, like it's not just, oh, maybe I'm just having a bad day or didn't drink enough water or whatever. What do they do next?
Yeah, so the symptoms typically come on very suddenly.
Yeah.
Usually, not always. Usually, nothing's black and
You're
white in medicine.
You're very non-committal.
What I've learned is that no one follows the textbook.
Yes.
And so ideally, they should come to the emergency.
Okay.
And be assessed. And what we would aim for is that someone undergoes urgent evaluation and imaging, within 24 hours, and that then they can be referred to our TIA clinic, and we can see them ideally quickly, and do the next steps from there.
Right. Okay. So the first thing would be go to the emergency department.
Yeah. And sometimes, because we cover all of interior health for stroke care, sometimes we may not see them immediately, like within that week at the TIA clinic, but some of the investigations and management have already been started appropriately in the emergency department. And so we have the discussion with the ED doctor on the phone, and we can advise. And then at some point they do see us.
Right.
Yeah.
And actually you make a really good point, because the stroke clinic here at KGH is like the referral center for the region. Is that correct?
Correct. Yeah. And we have some really great like TIA clinics also in Kamloops and Trail, for example, that can cover these smaller catchment areas and help us out. But otherwise, mostly we get all the referrals.
Right. Yeah. Right. So, okay. Basically, I want to know what the difference is between, I think I know the answer, but I just want you to articulate it, like a big capital S stroke and a mini stroke or a TIA.
What's the difference?
Yeah, like when would you be like, ooh, that's a full on one versus the baby one?
Yeah, so your symptoms aren't resolving. Okay. It's definitely it's a stroke. Like and either way, if you have stroke like symptoms, you should go straight immediately. You should treat it like an emergency.
Right.
And then get evaluated as needed. And some patients, they may resolve during the time that they're being transported to the emergency or in the emergency. But some patients may persist to have symptoms, and then we get involved.
Right. Yeah. Well, and I think it's good to just kind of like lay that out, because again, I don't know how much people realize that there are these sort of warning signals, or that there are different manifestations of stroke that aren't just sort of the really debilitating, serious, unresolved ones that we're, most familiar with.
Mm-hmm.
So I have a question for you, because I think it's important, especially when we talk about stroke care and we talk about like mini strokes or TIA, um, in terms of recovery, right? Um, what is neuroplasticity, and what role does it play in stroke recovery?
Neuroplasticity is, I suppose, your brain's way of remodeling and making new connections. Like, think of your neurons as like these little tree branches, and they all want to connect with each other. And then when you have a stroke, unfortunately, that area of the brain dies.
Mm-hmm.
And that
And
tissue
quite
is,
quickly, like when the blood flow's cut off.
it does die quickly,
Yeah.
exactly. And that's why we want to intervene quickly so we can reverse it if possible. But once it's established, the tissue is dead, but then all the rest of your brain that's still healthy can make new connections to compensate for the loss of function.
Mm.
And so that's where rehab becomes really key, because we know that early rehab, early mobilization is really good for patients
Right.
in the first few days of a stroke.
Right. So basically what you're saying is that the brain it has the ability to rewire itself if given kind of the right support early.
Yeah, I think the brain will rewire itself on its own, I think,
Right.
and having the right support will help encourage all those encourage things. And so, what I tell patients often is that recovery can happen up to like months down the road still. Like, it does slow down, but we do still see a lot of improvement. And it's actually really great to see patients in follow-up after they get discharged home from a stroke and months later, and they're like walking, and they've regained their arm and leg strength, and that's really nice to see. It's not
Mm-hmm.
perfect, but it's a big improvement than what they were like initially. And um ongoing like recovery involves like taking good care of yourself, good sleep, allowing yourself for good rest, and
Mm-hmm.
practicing movement in the weak side, for example, and using it. And then that allows your brain to make those new connections.
Right. So like the advice from, long ago, I feel like all specialties are sort of like ditching the advice of just rest and like lay in bed, and that would probably be counter to kind of what you would be recommending. Obviously, rest is important, good sleep, all of that, but movement also super important.
Yeah, exactly.
Mm-hmm.
Yeah, definitely.
Awesome. Okay. So, uh, I love the opportunity that we take on this podcast to talk about prevention. And I would love to talk about that with you, because it's one thing to outline the scope of the problem. But I think part of the opportunity we have here is to say, okay, like perhaps if we can make decisions, lifestyle choices, whatever it happens to be, to prevent strokes from happening. I found this statistic. According to our friends at the Heart and Stroke Foundation of Canada, up to 80% of premature heart disease and stroke can be prevented. These two are quite closely linked. So I'm just going to ask you, like, what are the most important lifestyle or medical risk factors? Two different questions, probably, to for people to know, like in terms of prevention.
So the most common, I guess, vascular risk factors are the usual culprits. So
Okay.
things
Yeah.
like high blood pressure, high cholesterol, diabetes, obesity, sedentary lifestyle,
Mm-hmm.
you know, bad habits like heavy
Smoking,
drinking, smoking.
no
Yeah.
judgment, but we know.
The bag of
Yes.
chips after
Yes.
all those things. Exactly.
What if
So,
it's just a little bag
yeah.
of chips?
And yeah, so those are the most common vascular risk factors. And um, definitely like making good lifestyle choices will be helpful for people in terms of reducing their cardiovascular risk over their life.
Mm-hmm.
And
Mm-hmm.
so
And what would you say those would be? Like just at a very basic minimum.
Yeah, I definitely always recommend the Mediterranean diet. We know that's the best heart healthy diet and
Oh,
brain health diet. It's proven to prevent dementia, for example, and it's good for stroke patients because of um, basically it's been shown it's basically the easiest one to follow, I think, in terms of list of ingredients. You can look it up, and so dietary choices like that are good, and definitely staying active, like aiming for some regular physical activity.
walking. We're
Maybe.
big fans of the walking on the Wealthy podcast.
Oh, yeah,
Yes,
exactly. Get a
just
walk
every
up
day.
Knox Mountain.
Yeah. Well, that's a ambitious walk.
Maybe take the or drive up there and then walk around.
Walk around.
Yeah.
Yes. Yeah.
But staying active.
Yeah.
Diet choices.
Sleep.
Sleep is important.
Yeah.
Definitely.
Totally. All the regular things, but basically we want to avoid becoming overweight and try to optimize our cardiovascular health, right? So staying active, keeping an eye on things like blood pressure and cholesterol and all of that. Yeah, it's going to really help mitigate that. Can you help us understand the connection? It is the Heart and Stroke Foundation. They're very intimately linked. And I don't know if people sometimes recognize, because we think of stroke as sort of like a brain condition, but what's the connection between cardiovascular health and stroke risk?
I would say the connection.
Like, why are they paired together, like heart
Yeah.
and stroke?
Yeah, I think I guess because your arteries in your brain are probably the same as your arteries elsewhere in your
Like
body.
they're connected.
Yeah, so same vascular risk factors in general, but and there are a lot of heart conditions like atrial fibrillation or heart failure or valvular disease that can cause a stroke too. So it's probably why they're connected.
Right, like more like on the vascular side of things.
Correct. Yeah.
And vascular is, I always think of it as like the transportation system in the body, like the veins and arteries and yes.
Yeah, it's like my analogy is that they're the pipes that send the blood flow to your brain.
Yeah.
So you don't want to clog those pipes.
No clogging of the pipes. Keep those pipes moving.
Yeah.
So you've sort of like answered the question around high blood pressure and that being a central concern in brain health. So for someone, circling back, like for someone who's had a TIA, what is an ideal prevention plan going forward? What would you be speaking to them about, just in terms of optimizing their chances of, or lowering their risk of having another one or a major stroke?
Yeah. I mean, ideally, when I see a patient in the TIA clinic, we want to first of all, like, try to figure out everything. Like, I look at their imaging, their CT angiogram, their blood work, and their heart tests, and then we can risk stratify. And in general, I counsel them all the things we just talked about. So like lifestyle and dietary choices, and then I know no one loves medications, but sometimes you need it just to help cover you in that period. So antiplatelet medications, which make your blood a little less sticky, I suppose.
Okay.
So less likely to form some clots, especially during that time period where you might be higher risk of a recurrent event.
Right. And is there like a time period that you are more high risk?
Yeah. So the first few weeks or the first several days usually are higher risk of a stroke. And that's why we consider it like a warning sign for a stroke.
Right. Yeah. Yeah. So listen to your bodies, people. And pay attention. I want to transition to women's brain health. This is, as I said, sort of in the opening dialogue, there are different characteristics for women's brain health as opposed to men's. Women are more likely to die from a stroke, and experience worse long-term outcomes. Why is that?
Yeah, I think it's a really good, interesting topic, actually. I think that we're just starting to understand the differences between women and men biologically in
Which is so
terms of,
funny, right? Like,
yeah,
because
definitely.
like we've been this way since the beginning of time.
Yeah, like, well, it's there's a lot of reasons, but just in terms of risk factors, there's a lot of social and gender differences to consider too. Like,
Hmm.
women tend to be caregivers, or maybe they're more likely to live alone, so maybe they're less likely to present quicker to hospital in some
And
places.
they also tend to live longer,
Y-
right? So you would have more risk, I think, the longer you
Mhm.
live.
And so there's all these differences in terms of their social cultural factors and also biological factors, like women in terms of their reproductive lifespan and hormonal changes, pregnancy, menopause, and women are more likely to have atrial fibrillation. And
Which
so
is what? Atrial
atrial
fibrillation.
fibrillation, so when your heart beats irregularly,
Irregular
essentially.
heartbeat.
Exactly. And so you can form clots in the heart, they get thrown up to the brain and
Right.
cause strokes.
Yeah.
Um, so there's all these differences that we're starting to recognize, and it's very interesting. And some studies have shown that women tend to have worse outcomes. They tend to less likely be discharged to rehab, um, more likely to go long-term care, and it varies depending on where and what country and where the study was done,
Hmm.
because there's multiple factors to consider, but it is interesting that there is a difference. And historically, women are less likely to be recruited into our clinical trials. And so a lot of
Right.
the data is skewed for a
Toward men.
population of that was predominantly men, like
Hmm.
70% males, and a lot of the carotid endarterectomy studies, for example. So it's it's just it's something I think that is important for us, because then we can better risk stratify more individually
Hmm.
and recognize the symptoms differently, for example, for women versus men.
Totally. And
Yeah.
also, just even identifying the risk factors for women.
Hmm.
I am in that lovely phase of life, the perimenopause change. So lovely. But I've recently learned that there's a lot of, other than the fun things that we all know about, right? Like the hot flushes and, sleeplessness and all of that good stuff. But there is an impact on cardiovascular health with the um, depletion of estrogen or the erraticness of estrogen. And so it's just interesting now that we're finally starting to recognize that women do have a different, I don't know, what would you call it, like pathology or diagnostic, like projection for these types of risks.
Yeah, they have different risk factors, and I think it warrants more like understanding and trying
Hmm.
to figure this out and taking that into consideration as well. Like, menopause is an example. Like, women who are on estrogen therapy is a different risk factor too. Um, Transgender individuals also on hormonal treatments is
Right.
something to consider. There are hypertensive disorders of pregnancy, all these things that can increase your risk of a cardiovascular event later on in life too. Like if you have hypertension, gestational hypertension, or
Right.
gestational diabetes or eclampsia, those are things that we should consider when we look at patients and think about their overall cardiovascular risk.
Right. And do you look at it like in terms of lifespan? Like if a woman presents with like preeclampsia in her childbearing years, is she at higher risk perhaps later in life for mini stroke, TIA, or like a stroke?
Yeah, these are definitely, that's something to consider. And I think I don't, there are little factors that may or may not be big importance in terms of their actual presentation later on in life, but
Right.
there are things that we think about when we see someone in the TIA clinic, for
Right. So
example.
if you see that, you're like, okay,
Yeah,
interesting.
it's a risk factor. Like we would consider migraines with auras to be a risk factor for
Oh,
stroke. And
interesting.
yeah.
Okay. What other things are risk factors? What other, like, do you have a list? Like, what,
Yeah.
1 foot bigger than the other?
I know. Definitely. That one I don't know, but we'll have to look for it.
I just made that one up.
Yeah. Like family history.
Yeah.
Some people are just born with certain conditions that may like increase risk of clotting. There's a whole list of them, depending on, and it's always a little patient specific, like what type of TIA or stroke they have,
Right.
and then what kind of questions or risk factor questions you want to ask about.
Yeah.
Yeah, but like cancer, for example, can increase your risk of clotting.
Right.
You know that. Yeah.
Oh, great.
So
Only bad enough I had cancer. Now I got to worry about this. I did have cancer, by the way.
oh, I'm sorry.
Yeah, no, it's okay.
Yeah.
Thank you. I'm okay now.
Okay.
I'm good. So circling back, you know, I mentioned also in the intro that sometimes the symptoms that women are experiencing that would conclude with, oh, you're having a mini stroke or TIA, are misread or missed entirely. Why do you think that is? Just because like we're such troopers and we're like, I can handle all things.
Yeah, I don't know if we fully know exactly why, but there are some studies that have been done where it's been shown that women do present with more atypical symptoms. So
Right.
non-focal symptoms like generalized weakness or dizziness or feeling confused. And women also tend to be misdiagnosed as a result, and then later get the revision of their diagnosis once we do an MRI.
Right.
And
Because then you could see it on an MRI.
Yeah, that's the truth machine.
Right. Yeah.
And so why that happens, I don't know exactly, and there could be things like maybe it has to do with the physician itself. Is there some bias in the interaction between the physician and the patient?
Well, and also some of those symptoms are so common to like just like so many other things like dehydration or lack of sleep or, hormonal changes that I can imagine it would be, I don't want to say easier because I definitely don't want to characterize medicine as easy, but maybe not as apparent,
Definitely. And I think that's why we want to be participating in this national study called Stroke Go Red.
Yeah, tell me about this.
So we're one of 4 or 5 sites across Canada where
KGH is. Yes.
Yeah, it's run out of Sunnybrook primarily. Dr. Amy Yu has a huge interest, and she leads a lot of the field on sex and differences in stroke. And so one of this particular sub-study involves, looking at these things like why are women more likely to be to have differences in terms of their risk factors for TIAs and strokes? Do they have different outcomes? Is there like a difference in the sex and gender association with the physician and the patient that alters their outcomes and their TIA workup?
Yeah.
And so that's part of what we'll be looking at with this.
Has this study started?
Hopefully soon this summer. That's the goal.
Yeah. And so KGH is a site, research site, and you mentioned there's 4.
Yeah, so the other places will be Sunnybrook,
which is in Toronto, right?
Sunnybrook in Toronto, correct. Winnipeg, Calgary, and then Vancouver.
Oh, okay. Amazing. Great.
Yeah.
And so the goal is to help answer some of these questions around why there is a difference between how it is presenting in women versus men.
Exactly. And are they investigated differently? Do they get different management? And what are the differences in terms of their sex risk factors and like gender-based risk factors that affect their outcomes?
Amazing. Well, we'll have to, when does that study wrap up?
It'll take several years, but
Darn,
we will
why
start.
does research take so long?
Hopefully we'll have, I think
preliminary. Yeah,
I think
findings.
within a year, like it'll be wrapped up in terms of data collection and study recruitment. That's the goal. So we're trying to start getting things running for this summer. and then it'll run for about a year, and then we'll start looking at the data and go from there.
Amazing. Well, you make sure that like we keep in touch
Yeah.
because I want to know what the results of that particular study are. I think it's really, really relevant. Um, so and you mentioned that part of the issue is that we just don't have the data on women because historically, for whatever reason, they haven't been included in these studies.
Exactly.
Yeah.
And it's really hard to tease that out because there's so many reasons, for example, why, but we don't exactly know why women might be under recruited in
Yeah.
clinical studies.
Yeah.
And it goes back to things like maybe just not as interested. Is
Yeah.
it because there's less women doing research and so they have less trust in the system? Women are more likely to be caregivers, so they can't step away
Mm-hmm.
to participate in research because the extra time involved
Mm-hmm.
that it might take. And so there's all these reasons, and we don't really know why, but also going back into that stroke or red study, one of the things we do want to look at is, are there ways that we can improve recruitment of women into clinical research?
Yeah.
And are there certain interventions like providing women-specific information or about clinical research that might help promote
Yeah.
recruitment?
Incentivize maybe women to. I think that's one of the things that I've learned over the last couple of years. I didn't really, um, we always hear about these studies. Like I quote these stats, and you just assume that it's like general population. It is, right? And it also represents a sample, right? So like it's not portable almost to everybody in the sense that like there are differences between men and women. Um,
Oh, exactly. Yeah. And, part of research is, yeah, everyone's different. We need to sample different populations.
mhm.
Like people who live rurally are different than people who live in
Yes.
urban centers. And there's cultural differences and
Yeah.
ethnic differences. And so um, that's why it's important for us to participate in research
Mhm.
so we can take what we know and then apply it directly to patient care.
Yeah. Yeah. Yeah, it's great. It's great work. I listen to a lot of podcasts, obviously. And one of the areas of interest for me is on the health side, but it's more sort of like longevity um practices and what's interesting is now they're starting to evolve like a whole conversation around a lot of the data that they have on like longevity studies is like based on men's data, right? And so it almost is like I don't know anymore if that applies to me because we're learning so much about how women are so different than men, and not in a bad way or in a oppositional way. It's just in a
Mhm.
different way.
Oh yeah,
Yeah.
no, it is. Yeah, and it's very interesting how a lot of the studies involve more men.
Yes,
Yeah,
totally. Yeah, yeah. And I'm grateful that you guys are doing this work. It's really, really good work. I want to circle back because you are a clinician, you see patients, and this is pretty vulnerable work because a stroke, I think it was one of your colleagues. He said it in a very elegant way, but most people, he said people are afraid of dying from a stroke, but actually living after a stroke can be really, really hard.
yeah.
And so, can you just kind of tell me, like, what maybe the emotional and psychological side of stroke recovery looks like from your sort of day to day work with patients?
Yeah, it can be challenging. I think some strokes are very severe and large, and even though our therapies and treatments for acute stroke management has dramatically improved and
Totally.
we can reverse strokes and improve outcomes, we don't always, it's not always like that for everyone.
Mm-hmm.
And so people can die from strokes. They can be fatal, and they can end up in long-term care and lose all their function. And
Mm-hmm.
that can be really difficult for patients and for families,
Mm-hmm.
because it's a big life change.
Mm-hmm. Mm-hmm.
Yeah.
And just you mentioned families, because I think that that's a huge part of kind of the network of caregivers for people that have survived a stroke. Um, like, what is it like for them?
It's very stressful. I think
Yeah.
families understandably come in with numerous questions, and they're very stressed, and it's a sudden thing. A stroke is sudden.
Right.
And so I think
They're
they're
not
also
prepared.
shocked. Yeah.
Yeah. Yeah.
Especially when they're just like, oh, now their loved one is in the emergency with a big stroke.
Yeah.
And it's a little bit of a shock sometimes. Um, so it's a lot for them to take in.
Mm-hmm.
And
What if somebody was listening right now that may have just experienced this,
yeah.
or for whatever reason stumbled upon this particular episode at the right time for them? What advice would you give a family member who is supporting a loved one who has just had a stroke?
Yeah, I think my advice would be, it's difficult, but you're not alone. There's definitely other people who um, are experiencing this too.
Mm-hmm.
And I think that the care team, we're doing our best sometimes to support. And I guess my advice would be, take things one step at a time. It's one
Mm-hmm.
day at a time. Sometimes we don't know exactly what the outcome will be. I've seen some patients, unfortunately, they just don't get better, and some patients miraculously do. And it's something that you only see slowly over time. And when you're supporting someone like a loved one with a stroke, I think really just focusing on how can we help them get through this, and like
Mm-hmm.
support them and
Mm-hmm.
help improve their quality of life in the best way we can
Right.
with what they have.
Yeah, and like even just allowing um the physicians and the specialists to take care of the recovery side, the rehab side. And as a family member, just I just think like loving that person and supporting that person, being there with them is I mean, I don't want to minimize it, but it's enough like to help them in their recovery, walk alongside them. I think trying to empathize with somebody in that position, it would be so overwhelming, because like there's all the
Yeah.
medical stuff, right?
Yeah.
And then there's the emotional, physical stuff.
Definitely. And sometimes I think that's all that sometimes some family members really just want. They just want some guidance through
Yeah.
that time in the hospital,
Mm-hmm.
um, or maybe just like some explanation of what's going to happen, because
Mm-hmm.
they don't really know what to expect. And
Yeah. Yeah.
it's difficult. There's a lot of unknowns during that time.
Yeah. Yeah.
Sometimes. So I usually just kind of I say that, it's one day at a time and see how things go. And it's difficult, but
Mm-hmm.
try to, we'll get through it.
Yeah.
And we always try to give as many answers as we can. And sometimes we can't give all the answers up front, but we try our best.
Right.
Yeah.
With the information that you have.
Yeah.
Yeah. That's all you can do. So what makes the Kelowna TIA clinic unique?
I think we're a great group of neurologists.
Of course you are. That's so unique.
And so
I love you guys.
I think what makes us unique, well, we cover like a really broad population, like a lot of rural patients actually, because most of our patients come from outside Kelowna. And so we cover a huge catchment. And I think that we provide telecare, remote care often, and that makes us unique from other sites.
Yeah. So just to kind of like double click on that, like the telehealth side is actually quite novel. So in the interior, the way that our health authority is set up is like the region is actually huge. Somebody told me it was like the size of Germany. I haven't actually been to Germany, but like it's big for a referral region.
The geographic span is huge.
Yes.
Yeah. And I think one of the challenges that we often face is these patients come from some of them come from very remote areas
Yeah.
where they have to go through really windy, difficult highways and roads. And we always want to offer like an in-person appointment for the first time visit, because it's better in person.
Yeah.
We want to see them, and counseling is easier in person, and then we can check their blood pressure, and our stroke nurse meets them as well. And those are things you can't do remotely, but there are challenges sometimes with some of these patients in really remote areas.
Yeah.
Like the Kootenays. Or
We actually build and operate Joanna's House, and we support a lot of families who have to travel to KGH for stroke care. So we're trying our best to be able to facilitate that in-person connection at the beginning, because as you said, it's so important. But the telehealth side of things is pretty awesome, because folks that live in these regional, rural, remote communities have access to, I would say, like, world-class neurologists that are here at KGH, whereas they might not be able to access that level of specialty in their rural communities.
Yeah, definitely. I think that because of telehealth and facilitating that, I think now these patients can see a subspecialist
exactly
that they wouldn't have access to otherwise.
Yeah.
In their area.
Yeah, fantastic. Okay. Time's flying. We're doing this over lunchtime too, because we had to, again, like I said, we had to steal Dr. Diana from her clinic. So thank you for that. I want to just shift gears a little bit and talk kind of about you. And you've worked in healthcare for a number of years now. It was a passion of yours. You got into this role. Do you think your definition of what constitutes health or healthcare has changed from maybe like young Diana to the person and the physician that you are today?
I think that in some ways it has. Like, I definitely appreciate more we're not going to make everyone perfect. I know that. And I think that what constitutes like a healthy life is always different for everyone. And I don't want to tell my patients like it's a one box fits all, like you all have to do this, eat this diet, etc. And at the end of the day also, it's like, well, what fits into your life and will fit into your lifestyle, and I guess also still add meaning to your life and help you enjoy quality of life at the end of the day. And so if it comes to like physical activity, just find something that you like to do, but don't force yourself to
hike knocks.
Exactly. If you don't enjoy it, I think you should find something that you enjoy to do as well.
Pickleball.
Yeah, exactly.
Yeah.
Pickleball is very active.
I know. My parents are like, they annihilate us at pickleball. Yeah. It's amazing.
Definitely broken a sweat at pickleball. Yeah. I would say find something you enjoy. I mean, living a healthy life is important, but also like you want to live a life that is meaningful and that you enjoy too.
Yeah. And I think that whole conversation around health and healthcare being more than just, fix what is broken, cure what is sick, and this idea that it's more integrated, like it's a lifestyle approach, as opposed to kind of like one, like, as you said, one size fits all, right?
Definitely. And it's different for everyone too, like in terms of what's important to them and what they value. Everyone's a little different. So finding out what works for them, I suppose, is important.
Yeah. Okay. So this podcast is called Wealthy, and it's sort of like a play on the word, in the sense that health, so it's healthy. Okay. Health is wealth.
Oh, okay.
I know. Are we not so clever? Yes. And just recognizing, as we've just talked about, there's like many facets that contribute to our overall health and well-being, that aren't just physical. I'm going to put you in the hot spot. What areas of your life do you feel that you are wealthy or abundant?
Ooh, good question. I just did my first 100-kilometer bike ride,
Wow.
which
Yay,
I didn't think
you.
I would achieve this early. It was more of a goal for the end of summer. So that has been like really great for me. I think just here, moving since I've been in Kelowna for the past year, because of all the easy outdoor access, an abundant part of my wealthy lifestyle has been enjoying the outdoors and just like biking, hiking, getting outside. It's been really great. Like it's so easy here because everything's so close and
Out your
accessible.
door. Yeah. Where did you move from?
I am originally from Lower Mainland,
Okay.
and then I did my fellowship training in Calgary, and then here.
Okay.
Back here.
Yeah. I'm originally from the Lower Mainland too. And I love it here. I know exactly what you're saying about just we have such a plethora of opportunities to engage in lifestyle activities that are so healthy for us just by like opening our front door and walking outside. It's really amazing. And I think by virtue of the fact that people are choosing to live here, people are choosing that or recognizing that that's such a huge part of overall health is being in a community and being in a place where living a healthy life is easy. And I feel like it's definitely easier here than, say, for example, I grew up in the Lower Mainland. It's not as easy there, right? It's a little, you have to make a little more time for things. Also, because you're commuting, I had to commute like an hour each way. It was like a lot.
It's the worst. Yeah. Commuting is really difficult.
Yeah. Sometimes people like complain about commuting in Kelowna, and I'm like, 15 minutes isn't so bad.
It's not. It's really nice, actually.
Yeah, totally.
Yeah, I agree.
Well, thank you so much for joining us today. It's been a pleasure to have you. I know I've pulled you from clinic and into outside of your comfort zone. But thank you so much for sharing all of this really valuable information on stroke care, warning signs. So valuable. None of us are getting any younger. We haven't figured that one out yet. Maybe the robots will figure that one out. But until they do, it's really, really important for all of us to be able to see and recognize what a stroke looks like.
Great. Thanks for having me. It's a lot of fun.
Yeah. Thank you.